Okay. All right. Thank you, Hitesh. And welcome everyone for today's talk. I'll be talking about intraoperative injuries to collateral ligaments in total knee arthroplasty. This is definitely a very important topic because total knee arthroplasty is one of the common surgeries we do. Let's start. So collateral ligaments are very critical, and the integrity of collateral ligaments are very critical for a successful total knee arthroplasty. Instability following total knee arthroplasty can lead to residual pain, swelling, and poor function. And it has been shown by many studies over the last several decades that it's one of the very common reasons for revisions in total knee arthroplasties. Failure to recognize these injuries and appropriately manage them during the surgery itself can compromise the patient outcomes and of course the implant survivorship in the long term. So let's just a quick look at the anatomy and the biomechanics of the collateral ligament. So the medial stability is primarily provided by the medial collateral ligaments, which has two parts: the superficial and the deep MCL. So that arrow demonstrates the deep MCL. The MCL origin is from the medial epicondyle on the femur, and the deep MCL from the medial epicondyle, it runs towards the distal aspect and attaches to the proximal medial tibia at the level of the joint line here, and part of it also attaches to the medial meniscus. The superficial MCL ligament, it runs all the way down. It's a much longer part of the MCL, and it attaches about 4 to 5 centimeters distal to the joint level, somewhere over here at the deep to the pes and serine tendons. Medial stability is also provided by the hamstrings and the posteromedial capsule, which is demonstrated here in this picture. Lateral side, the lateral stability is primarily provided by the lateral collateral ligament. As we can see here, let me get this one down. It, as we know, it arises from the lateral epicondyle and runs and attaches to the head of the fibula. The lateral stability is also provided by the IT band, iliotibial band, which attaches over the Gerdy's tubercle over here. And then the popliteus tendon, as we know, it's also an important dynamic stabilizer, and the posterolateral part of the capsule. So the incidence of the collateral ligament injuries has been found to be about somewhere between 0.5 to 3% in different studies. Of that, we know we can classify them mainly as avulsion type injuries, which have been found to account for about 59% of the total injuries, followed by the mid-substance disruptions, which is about 41%, according to this meta-analysis systematic review published in 21. But different authors have documented different proportion of these injuries. So there looks like they're almost 50-50 here. The lateral side injuries are definitely much less common, and there are not many reports in the literature, so I couldn't really find the incidence of lateral collateral injuries, mainly because we know the varus deformities and varus deformity correction is the most common type of total knee arthroplasties we do. The valgus type of deformities are much less common as compared to varus deformities. So intraoperative medial collateral ligament injuries can happen during different stages of total knee arthroplasty. The first one is, of course, during the exposure. So this can, when we're dealing with a difficult exposure, when we try to sublux the tibia, then it's possible to avulse the ligament most often, either from the femoral side, or can avulse from the tibial side also. So it's very important to develop a good proximal medial periosteal sleeve from the proximal tibia here, so that we can easily subluxate the tibia forward. And also it's very important that we take down the big osteophytes from the proximal medial tibia, and especially a large osteophyte like this from the posterior medial aspect of the tibia. Otherwise, this can interfere with the exposure and interfere with the anterior subluxation of the tibia, thereby that can increase the risk of injury to the medial collateral ligament. Next, it can happen when we're doing the tibial cut and the posterior medial femur condyle cut. This is from the direct saw blade injury. So it's very important to have appropriate protective retractors placed deep to the MCL when we are doing the cut. And also, it's very important to angle the saw blade away from the medial collateral ligament. Also, it's very important to use appropriate size saw blade so that it is not bigger than the cut we are making, not bigger than the posterior aspect of the femur condyle itself. So that's where we do the posterior femur condyle cut using the 4-in-1 cutting block. The injury can happen when we are trying to balance the knee in a varus deformity. Obviously, the medial side is tight, and after we take down all the osteophyte, after we do the primary cuts, then when we are balancing the medial side, we try to there are different techniques which can be done. Typically, either we further release the medial side along the posteromedial aspect and the deep MCL, and sometimes going down all the way to the distal aspect of the medial collateral ligament. And the other technique called the pike resting technique, where, as shown in this picture, either a 11 blade or a small 18 gauge spinal needle can be used to make some multiple puncture holes so that we can stretch the MCL. So during these techniques, sometimes we can over release the MCL, thereby opening it up significantly more than we want to. Avulsion type injuries can also occur during hyperflexion of the knee for exposing the tibia. And then also they can occur when we're doing the reduction of the knee after placement of the trial components or after final components. And less commonly, it can also happen if we do vigorous varus valgus stress testing when we're assessing the stability of the knee. That can also result in MCL injuries. So most of this talk is going to be about MCL injury, but that's the most common type, and that's what is most often reported in the literature. So there are other risk factors which have been described by many authors. One of the common one is obese patients. So morbid obesity was found to have a higher incidence, and it can be as high as 8% reported by these authors. And then female patients are at a higher risk, probably mostly because they have higher incidence of osteoporosis. Pre-existing severe deformities also increase the difficulty of the exposure, and also we had to release more. That can increase the risk of injuries. Pre-existing injuries to collateral ligaments, like for example, combined ACL and MCL type of injuries. And in those patients who had ACL reconstruction done in the past, they probably had some injury to the MCL, which healed without surgery, and it is not as robust, as not good quality as a normal MCL. And when we're doing the total knee arthroplasty for these patients, then then they have a higher risk of injury to the MCL. Use of large size saw blades that have excursion distances wider than the width of the femur condyles. We talked about this before, so this can also obviously increase the risk. This particularly so when we're doing the posterior femur condyle cuts. So it's very important to recognize these injuries during the surgery so that we can take care of them. Otherwise, there is higher risk of post-op instability and poor function. So it's very important to recognize them. So how do we recognize them? Number one, there could be sometimes, if this happens, we might see a sudden improvement in the surgical exposure. So we might be struggling with the exposure for some time, and then suddenly, next time we look at it, there is a bigger, the exposure is much easier. that should increase the suspicion for a possible ligament injury. Preferential and unexpected laxity of a compartment as compared to the other compartment, like in a varus knee, the medial side is supposed to be tighter than the lateral side. And if we find that the medial side is opening up more than the lateral side, then that's definitely an indication that there is injury to the MCL. There's significant mismatch between the polyethylene insert thickness and the amount of the bone resected. So if we did the usual bone resection, and if we have to end up using a significantly thicker poly like 14, 15, 16, we should be suspicious about these things. So generally, a high index of suspicion that something is either not normal or unexpected should prompt further investigation and evaluation of the knee joint. So how do we evaluate this? One of the simple ways is to use this laminar spreaders like this. We often use the laminar spreaders to assess the gaps, and when we put laminar spreader and stretch it, and if we find that one compartment is significantly opening more than the other side, that we should be evaluating that further for the collateral ligament injury. Another technique is using the spacer blocks. So we often use the spacer blocks to assess the gaps again. So this can use them to evaluate the gaps, and they can give us a good idea. And of course, after we place the trial components like this, if we see a significant laxity in one of the compartments, that's an indication that there is injury to the collateral ligaments. Once we recognize that there is injury to the collateral ligament, next step is to identify where the injury is, because this is very important as far as further management and the treatment options. So the injury can be intersubstance, or also called the mid-substance injury, which is most often is due to direct injury from saw blades, and the other possibility could be avulsion type of injury, which could be from the femur side or from the tibial side. We should also evaluate the other factors like integrity of the remaining part of the retinaculum and the quality of the tissues, all those things, because they have important consideration regarding the treatment options. So that shows there is a mid-substance injury there, a complete tear of the MCL in the mid-substance, and this lower picture shows a complete release from the tibial side. Various treatment methods have been described by many authors over the last many years, including non-surgical conservative treatment, primary repair, augmentation with tendon grafts, fixation with screws and washer, and using a thicker polyethylene liner, and finally using an increased prosthetic constraint. And there are many reports about using these techniques and various combination of these techniques. So I'll go over some of the reported literature here. So again, these are not common injuries, and it's not like there are several reports, and most of them are like usually most of the number of cases they have is usually like in the double digits. So this study, conservative management of after intraoperative over release of the medial collateral ligament from its tibial insertion after a total arthroplasty. So this was a retrospective study of MCL over release, and there were 47 knees in 40 patients. They compared this with an intact MCL group, which included 502 knees. So primarily the issue was a detachment of the superficial MCL completely off the tibia. So what they did was they just simply sutured it or anchored it beneath the pes anserine tendon using a 10 Vicryl. They did not do any further, any complex type of, reattachment or bone anchors or anything. So just simply sutured to the pes anserine tendon using the 10 Vicryl. And they used the standard size poly without any size adjustment. Post-op rehab was also not different. So they did not do any bracing, and they allowed full range of motion with full weight bearing. So there's a couple of charts here showing their results. I don't know if I can do this. Yeah. So they use the Knee Society score for evaluating their results. They did not find any significant difference between the two groups. They found there was none of the patients reported any medial instability, and on clinical examination there was no laxity. There were no cases of aseptic loosening. And the estimated survival was about 13 years for both of them. I'm sorry, estimated 13-year survival was also not significantly different. There were no revisions due to post-op instability during the follow-up period. They found that based on their preoperative, the preoperative data, they found there were no difference in the demographics. But the patients with over-released MCL group, they had a higher flexion contracture as compared to the control group, and their also range of motion was less as compared to the intact MCL group, and they had more varus deformity compared to the control group. So that indicates that these the patients who had MCL injury, they had significantly more deformities and also contracture as compared to the patients with intact MCL group. Another study here, disruption of MCL during total knee arthroplasty. They reviewed 600 knees from 91 to 97. The location was either the femoral origin or the tibial attachment or mid-substance injuries. Tibial avulsions were repaired with suture anchors. One femoral avulsion was repaired with screw and washer, and mid-substance tears were repaired with heavy braided non-absorbable sutures. They had 16 knees with MCL injury. 12 of them were cruciate retaining knees, and 4 of them were posterior stabilized knees. And thickness of the polyethylene was determined after the repair was done. They allowed full weight bearing with a hinge knee brace for 6 weeks. And 3 of the tibial avulsion and 1 femoral avulsion in severely osteoporotic patient. I'm sorry, 3 tibial avulsions and 1 femoral avulsions happened in osteoporotic patients, and 12 of them were mid-substance injuries. Mean follow-up was 45 months, and again, they did not have any increased incidence of revisions. None of the patients reported instability, and there was no demonstrable clinical laxity. 13 of the patients had excellent results, and 3 had good results according to the HSS score. Another study here by Lee and Lotke. So this was again a retrospective review of 1,650 posterior stabilized knees from 1998 to 2004. 37 of them had MCL injuries, 2.2% incidence, 18 male, 19 females, 54-month average follow-up. 28 cases were transactions, mid-substance injuries, and 9 of them were tibial avulsions. 5 cases they did end-to-end suture repair, and in 9 cases of the tibial avulsions, they stapled the ligament onto the tibia. In 30 of the 37 patients, they used higher constrained implants, which is the TC3 type, it's the revision type of implant. Patients who were treated with higher constrained TC3 implant, they were allowed full range of motion and full weight bearing. 4 of the patients who had repair were actually casted for 4 weeks. So they found that 4 of the 7 patients who were treated with unconstrained inserts, that is the standard PS inserts, required revision for instability at an average of 7 months. And 3 of the 30 patients who were treated with TC3 required required revisions, and 1 of them required revision for infection, 2 for aseptic loosening. So when they looked at the Knee Society score, there was definite significant difference between the study group and the control group when they looked at the study group as a whole. that is the 37 patients in the study group, their pain score was lower, their function score was also lower. But when they looked at the subgroup of the patients who had constrained implants, there was no significant difference in the pain and the function scores. That means those patients who had constrained knees actually did better as far as the pain and function is concerned. So the PS knees had PS knees which did not have further constraint, had higher incidence of injuries, and they thought this could be because the PCL is an important sagittal plane stabilizer, but also provides significant coronal plane stability. So the PS knees probably are at a higher risk of developing further instability when there is a collateral ligament injury as compared to the CR knees. So another study here where they did reconstruction of the MCL ligament. So another retrospective study, 2,054 knees between 2007 and 13. They had 17 MCL injuries, 51 months follow-up. 12 of them were midsection injuries, and 5 were avulsion injuries from the femur. They did the MCL reconstruction using a semitendinosus single stand autograft, and all of them were cruciate retaining knees. So they did a double bundle type of reconstruction here. They made a tunnel. It's a nice paper. You can look at the technique. They have a nice description of the whole technique there. So a tunnel in the tibia, and then they pass the semi-T tendon and then anchored it into the socket here with the biotendinosus screwed into the medial epicondyle. So they also demonstrated good results with this technique, and no patient experienced any instability requiring revision. But definitely there was some difference in the pain and the function score as compared with the control group, and it was statistically significant. Another study here where they used a synthetic mesh to augment the repair. 3,000 plus total knees, 15 knees had injuries, mid-substance injuries in 11, and tibia and femur avulsions in 4. So they did an end-to-end repair in mid-substance tears, like using a modified Kessler technique, and then used this synthetic polyester graft, which was sutured on the outer aspect of the MCL. Using non-absorbable sutures, and they did the repair using with the spacer in place. None of them had any constrained implants. Range of motion was allowed with hinge knee brace. Again, there were no revisions for instability, and knee society scores also demonstrated good to excellent results. There's another technique, 14 patients, average age was 63, 12 women, 2 male patients. Half of them were femoral avulsions, another half were from MCL laxity, which they thought was because of increased over-release during the deformity correction. Average follow-up was 15 months, and the mean range of motion was 104 degrees. The HSS score was 85.6. So they repaired the femoral avulsions using this spiked washer and a screw as demonstrated here. And when there was MCL laxity, the portions of the MCL adjacent to the femoral origin was overlapped, and it was pressed by the rectangular spiked washer to thereby decreasing the laxity of the ligament. So they also demonstrated none of the patients required revisions. There were no manipulations. No patients reported clinical instability. There was no laxity on clinical examination during the follow-up period. So this was a meta-analysis and a systematic review published in 2021. They included 15 studies. There were 376 knees with MCL injury and 5,000 plus knees in the control group. 166 were mid-substance injuries and 220 were avulsion injuries. So avulsion injuries were slightly more common compared to the mid-substance injuries. Knee society score was reported in 9 studies, and after the data analysis, they found that patients with MCL injury had significantly reduced knee society scores compared to the intact MCL group. Range of motion was reported in 6 studies. 3 of those articles met the inclusion criteria, and MCL injury group patients had worse mean postoperative range of motion as compared to the control group. 4 studies were included in the analysis for complications, and 3 were included for analysis of revisions. Both the complications and revisions were 6-fold higher in the MCL injury group as compared to the control group. Just some information about the constrained implant. So this is something called a constrained posterior stabilized implant. So it's the same PS femoral component. Only difference is the notch is a little deeper. This is where we make the cut so that the notch is a little deeper, and the post is thicker and longer than a standard PS knee. Thereby, it can provide more medial lateral stability, unlike the PS knee, which does not provide any medial lateral stability. And of course, we have the further constrained revision type of implants, which provide much more significant medial lateral stability. But there are several limitations for these constrained implants. So the talar tibial post can be can potentially fracture because of the additional stresses, and it can be an additional source of polyethylene wear. And using these implants can require further release of the lateral compartment, which is otherwise normal. These implants can raise the joint line, thereby leading to kinematic imbalance and thereby postoperative pain. Constrained implants can also increase the stress on the bone cement interface and prosthesis bone interface, thereby increase the risk of aseptic failure later, and accompany greater bone loss can make further revisions difficult, and these are not readily available when we need them. So because many hospitals don't carry them on the shelf, so they're not readily available if you want to use them. So the take-home points, prevention is definitely most important, and because we know the collateral ligament injuries can significantly affect the outcomes. If once it happens, it's very important to recognize this injury so that we can take care of them. Once we identify them, then we have to identify the zone of injury. Unfortunately, there's no as we saw many papers over there, there's no real consensus on what's the best way of managing these, and authors have utilized different techniques and a combination of different techniques. But the general some of the basic the concepts are, we had to identify whether these are avulsion type injuries or mid-substance injuries. And if they're avulsion type, most often they can be repaired with either suture anchors, or in osteoporotic bones, we can probably use this spiked washer with screw technique, especially in the avulsion from the femur. In tibial avulsions, they as we have seen, many authors have demonstrated they do well without any definite repairs, but we can do simple repairs, or we can anchor them with suture anchors, or even we can use spiked washer and screws. Mid-substance injuries, if we end up unfortunately having the mid-substance injuries, then we have to consider other important factors, like what's the extent of injury, whether it is partial or complete, and the quality of the tissues, age of the patient. And we have to, along with the end-to-end repair, based on the other factors, we may have to consider further augmentation, either with an autograft or an allograft, or with a synthetic graft, and sometimes maybe using a higher constrained implant also. And that's about it.
Thank you, Prabhu. Prabhu, you can stop sharing.
Okay, let me just do that. Give me 1 second. Stop share. There you go.
Yeah. Thank you, Prabhu, for this wonderful presentation and a lot of new insight. Yeah, Prabhu, let's have a short Q&A.
Sure, definitely. Yeah. Yeah, thank you. It was and definitely this is a very important topic because we definitely nobody wants to have them, and I don't think any of us want to have a lot of experience in these, but they happen, especially if you're working with trainees or residents. They happen, and when you're in the early career, then it's there. They happen. So we should know how to take care of them.
Thank you, Prabhu. Prabhu, just for the interest of the audience, I want you to explain what is your sequence of release in a standard
Mhm.
TKR for a varus knee. How do
Yeah,
you?
sure.
Yeah.
Sure, definitely, yeah. So the first, once we make the standard approach is the medial parapatellar orthotomy. So once we do that, and once we, take out some of the fat pad in the way, then I start releasing the proximal medial, periosteal from the tibia. So the incision is just medial to the patellar tendon at the level of the tibia, and we cut right through the medial meniscus, and then we can any part of the meniscus which is still along the medial retinaculum, it may take out that, and you have to be careful when you're cutting it out, then you can injure that. Then I start depending on anyway this the release has to be obviously titrated. We don't want to use the same release for every patient. In a normal standard knee where there is no flexion contracture, and preoperatively if you are able to bring the knee to neutral, then we really don't need to do much releases. But in all the knees, I think we had to do definitely we had to develop that proximal medial periosteal sleeve along with the deep MCL. I would definitely release the deep MCL in almost all the knees. Otherwise, you can't subluxate the tibia forward. So it's a V shaped. So you start releasing but usually about 2.5 to 3 centimeters below the joint line, and then you start going towards the deep MCL. And once we get to the deep MCL, you can put a retractor there, either a bent Homan or a Z-type retractor, so that it's under tension, and release the deep MCL off the proximal medial tibia, and that should be it for the initial exposure. We don't want to go anything further, and then I start removing all the osteophyte from the proximal medial tibia, and typically that should be enough for the initial. And later, I usually do the femur first, so dislocating the tibia anteriorly is much easier after you finish the femur first.
Thank you, Prabhu. And in case you go further and you, especially in this part of the world where you see a lot of severe varus deformity. So in those cases, deep MCL, the osteophyte removal, then go slightly posteromedial, and then the semimembranosus.
Yes, exactly. Yeah, that's the same
To the
sequence. So
capsule.
to the capsule, all the way to the postomedial capsule, and the semimembranosus. It's a dynamic stabilizer, so it can be stretched out. So if needed, I would release it. If it is still tight, if the gap is not balanced, then I would release it. And if it is still tight, then I would put my laminar spreaders and see how much further release that needs to be done. Then if it is smaller release, probably another 2-3 millimeters, then I would do the pie crusting. So I keep it in 90 degrees, use a laminar spreader there, and then use an 18 gauge needle to do the pie crusting. So most of the time, large majority of the time, that should be enough.
And the last stage, maybe the PES answering.
Yeah, last day would be, you have to get to the superficial MCL. To get to the superficial MCL, you had to go through the pes and serine, and then if the deformity is, severe, you had to take down, basically strip the superficial MCL completely. Then, there are many papers on that. Most of them do just, fine, because the MCL has a good healing potential. And even without doing anything further, just leaving it alone, probably most of them do just fine. But once you can place some anchors there to repair it down, or maybe even washers, screw with the spike washers.
Thank you, Prabhu, for that. And Prabhu, suppose there is a complete MCL injury. I mean, you've gone through the entire spectrum of options,
Yeah.
right? For example, can we just do, on a practical sense, can we just do a repair primarily? Like you said, if it's an avulsion, go with some sort of suture anchor or a washer, spiked washer. And if it's a mid substance, you repair. And in case if it doesn't, I mean, it still lacks. Do you think a semi-T reconstruction makes sense? Because it's a bit easier procedure. We do a lot of, I mean, any MCL reconstruction using the semi-T. I mean, we all knee scopy surgeons as well. So doing a semi-T reconstruction would be easier, right?
Yeah, so I think so. In a younger patient who is more, going to be more active, rather than going for a constrained implant, I think this is probably better to, do a MCL reconstruction with the semi-T graft. There is another technique of that, the synthetic graft, many times that may not be available. The pes sensory tendons are right there. Of course, it increases the surgical time, but we had to take care of it. So I think, yeah, that's a very good technique described by that. And they had, good results. And all of them were, I think they were all CR knees. So they didn't go upon the constraint. I don't think they increased the thickness much. I think definitely in a younger active patient with good bone, good tissues, good healing potential, probably that's the way to go. But someone who is, elderly, less active, then probably I would, repair it and use this the constrained posterior stabilized, which is just a polyethylene insert. We don't need to change the femur or the tibial component. It's just a slightly deeper cut in the notch, and it does actually provide pretty good stability medial-laterally, and protect them postoperatively. I think most of them do fine.
And Prabhu, do you have the CPS insert always on in your operating room?
Yes, yeah.
Then,
So in our operating room, we always have that inventory. It's not a huge inventory, compared to having the full set of either a TC3 or a LCCK type.
but you need to take another notch cut, right? Which is slightly deeper.
It's just
Oh, it's
slightly
the same.
deeper. It's the
Okay.
same. So notch cut. So the medially lateral is the same. So for a PS knee, there is a slot for the CPS. So for a PS knee, you don't need to do that. You just need to, keep superficial to that. And if unfortunately, if we had to, use the CPS poly, you just, go just into the slot, use the same reciprocating saw, but cut through the, slot there. That should be enough.
No, yeah, this CPS should be very useful, because especially when you're dealing with the valgus knee, when it's going to be useful, isn't it?
Yes, definitely. So in a valgus knee, when you had to many times do the releases, yeah, it's very useful. Yeah, it's not a huge constraint, and it definitely gives good amount of stability.
Thank you, Prabhu. Prabhu, I think that's all the questions for this program. Thank you for yet another wonderful presentation. And of course, we really look forward. All your lectures, all of them have crossed 15,000, 20,000 views.
Oh, that's good to know. Yeah, that's good. I'm happy to, happy to be part of this, and I'm happy that this is helping, the many of the viewers.
Thank you so much. Bye-bye.
Thank you. Thank you.